Welcome, everyone. Now that we're all set, I would like to introduce all three of our speakers. Krista James is a lawyer and the National Director for the Canadian Centre for Elder Law, CCEL. You'll see that acronym today. Her work addresses legal and policy issues linked to aging. Krista has a particular interest in how aging, gender, and other aspects of identity intersect. Jessica Fehrenbacher is a social worker practicing in healthcare. She's also the coordinator for CCEL's Engaging People Living with Dementia in Decision-Making project, which is what we're here to talk about today. Jess believes in the worth of each person and in their right to make choices about their lives. And last but certainly not least, Myrna Norman is an advocate for people living with dementia, their carers, families, and communities. Myrna became an advocate after being diagnosed with frontotemporal dementia in 2009. She's also a writer and an active member on multiple committees. So welcome to all of you very, very much.
So thank you everyone for registering for this webinar and coming to hear from Myrna, Jess, and I. Today we're going to be talking about our Engaging People Living with Dementia project, and also I will be talking about healthcare consent law. So here's an outline of what we're going to cover in our presentation today and the flow. Jess, if you can move on to the second slide. Jess is going to be driving the slides today because I have too many things to manage at once right now. So anyway, I'm going to be talking about healthcare decision. Well, I'll briefly introduce our project and the work of the CCL, and then talk about healthcare, who makes your healthcare decisions. I'm going to mention supported decision-making and how it differs from substitute decision-making. Myrna is going to share some of her experiences and as living with dementia and advocating for her own decision-making rights. And Jess is going to share some of what we've learned from the first year and a half of our project on engaging people living with dementia in decision-making. Close to the end of my little part of talking, I'm going to be showing you an animated video that we developed a couple years ago with the Alzheimer Society. So just a few words about the Canadian Centre for Elder Law, which is where Jess and I work. We are part of a non-profit organization called the British Columbia Law Institute, which is BC's independent law reform agency. The CCL, we don't do advocacy, we do research, and we develop reports and educational tools to help folks from across the country to understand legal and policy issues related to aging. And you can see the URL for our website on the slide. It's also going to be on the final slide. And we put all of our materials up on our website so you can find them for free and make use of them in your personal decision-making, your personal life, and also if you professionally work in long-term care or in healthcare, we are happy if you're sharing our tools and using them in our work. So just the following slide, just a brief snapshot of some of the other things that we're working on. We have a project on elder abuse and neglect, looking at law in Canada, and we'll be publishing a new website, a bilingual French and English website starting in April that tells you what the law is in each province and territory in Canada, so Turtle Island. We have a project where we're looking at work of healthcare assistants. So they're pretty integral to long-term care, and we're looking at the legal system and how it has some oversight or doesn't have adequate oversight of their work. We have a project that might interest a lot of you on participation of people living with dementia in research, collaborating with researchers in different disciplines, and also with people living with dementia. And that work is funded by the Alzheimer Society of Canada. So we'll be looking at the law across Canada for consent to participate in research. And we will be publishing some resources to help researchers understand the law better, and so that they can do a better job of respecting the rights of people living with dementia to decide whether or not and when they want to participate in dementia research. And then just finally, there's a box there on capacity and decision making, because it's really an underlying theme in so much of our work, and a lot of the resources that you find on our website deal with capacity and decision making. So the project that we're sort of speaking to you about today is our Engaging People Living with Dementia project funded by the Vancouver Foundation. This project has really ambitious goal of changing how healthcare decision-making is approached so that people living with dementia have a voice and are meaningfully engaged in everyday decisions that matter to them, like about healthcare, about personal care, the whole range of decisions. There are lots of systemic barriers that get in the way of people living with dementia being involved in decision-making. The next slide, there are a couple of objectives we have to help us achieve this goal. So we are partnering with people with different kinds of disabilities, family care partners, healthcare professionals to identify the barriers to being involved in decision making and also the strategies that help people to be more meaningfully involved in their own decisions when they're living with dementia. And so what that means in our work is we're talking to people living with dementia, but we're also talking to people who live with other kinds of disabilities. And part of the reason why we're doing this is that we've heard that people living with dementia and their families, they're often new to living with a disability, whereas people who have had disabilities for most of their adult lives and their family members develop a lot of skills just from personal experience. And we want to share their strategies with the dementia community. And then the other project objective is to create strategies to support families and healthcare professionals a capacity to engage people living with dementia in decision-making as much as possible and in meaningful ways. So that could involve publishing tools, being involved in webinars, meeting with people in person. So we're trying to hear from people with dementia about what are the best strategies and then build our project around what we hear from you. So we have 3 partners in helping us to do this Vancouver Foundation funded work. The Alzheimer Society of B.C. is our major partner, also working with the Centre for Research on Personhood and Dementia, which is based out of University of British Columbia, and also with Family Caregivers of B.C. They're a BC-wide organization based out of Victoria that represents and supports family caregivers, supporting people with all different kinds of disabilities, but certainly including dementia. Now, as I'm going to be talking about legal rights shortly, and just a reminder that you have access to a PDF of my slides through the chat. Also happy to send them later if you miss them somehow, so you don't have to feel too pressured to write notes on what I'm saying and keep up with everything I say. Also, there's an email and social media for reaching us in our final slide. And so I'm going to be I'll respond to emails if people reach out to say they're having trouble. I'm just going to take a moment to plug in my laptop because I'm getting a notice that the battery's low. So just sit tight for a moment. I definitely don't want to discontinue from you. So the slide you're looking at right now, you can see our Dementia Advisory Council. We have advisory committees that support all of our work at the Canadian Centre for Elder Law. And for this project, it's a Dementia Advisory Council that's leading this work. So just to introduce the council on this slide, going from left to right. So the first gentleman you see is JP Dame. Then you see Myrna Norman, who is part of our presentation today. Then Jess, who will also be speaking today. Lynn Jackson is next in blue with the beautiful Forget-Me-Not scarf. Jerry Gosling, Craig Burns, and then finally Mario Gregario. Probably a lot of these faces are familiar to you because they are all advocates for the rights of people living with dementia and involved in the work of the Alzheimer Society. So now I want to talk a little bit about the law. I'm a lawyer and I'm not going to give you legal advice today, but I would like to help you understand the law and how it applies to healthcare decision-making and the rights of people living with dementia. So this slide here identifies some of the key parts of our healthcare consent laws in BC, and I'm going to go through each of these 4 points. So first and fundamentally, there's no treatment without consent unless there is an emergency. So an emergency would mean you're in the hospital or some urgent situation and that care is required by physicians or others to save life, prevent serious physical or mental health consequences, or to alleviate severe pain. Aside from that kind of emergency, a physician and a nurse, they cannot provide treatment without consent from the right person. And in most cases, you're providing consent for yourself, even if you're living with dementia. To provide consent without treatment is a battery, so it's a crime. So remember that physicians recommend treatment and they often give us good advice, but they don't make healthcare decisions for us. We make decisions, or our substitute decision makers do, and this applies in hospital, doctor's office, and importantly, it also applies in long-term care. Second, there's a presumption of capacity in our laws in BC, and that applies regardless of disability, age, or frailty. And that presumption applies after you have a diagnosis of dementia too. So unless somebody has gone to court and a judge has issued a guardianship order, this is called a committeeship in BC, saying that you can't make any of your decisions and a guardian makes decisions for you, this is a rare circumstance. Unless that's happened, we presume you have capacity to make your own decisions. And you have kind of a fresh start with capacity every time a healthcare decision needs to be made. So nurses and doctors always need to consider every time they're treating someone who's living with dementia, and assume they can make their own healthcare decisions, unless there's indication that they can't, the indication that they can't understand things. So third, if a person cannot consent, consent has to be from the right person who has legal authority to consent, not necessarily just the person who happens to be in the room at that time. The healthcare provider has a legal and an ethical obligation to get consent from the correct substitute. So this could be a representative if you've created a representation agreement for yourself and you've appointed someone to make decisions for you. It could be your guardian if someone has gone to court to get a guardian. But if you can't make decisions for yourself and there's no guardian and no representative, then the healthcare provider needs to get consent from what is called a temporary substitute decision maker. And what this means is that someone in your family, next of kin, it could be a family or friend, and they are trained to know what is the sort of descending list. So if you're married, for example, the first person they would consider is your spouse. Your spouse would be your temporary substitute decision maker if you haven't chosen someone else. If you don't have a spouse, it would be one of your adult children. And they kind of go down this list. If there's nobody in your family and no friends who could play that role, then in British Columbia, healthcare providers are required to contact the public guardian and trustee, and they may take on the role of being your healthcare decision maker or finding someone to make from your community to make decisions for you. And then fourth, and very importantly, consent must always be informed. And what this means is that the people who are involved in healthcare, it could be a physician or a nurse, maybe a pharmacist, they need to help you understand the condition you have and the kind of treatment that's being proposed so that your decision is informed. And now, importantly, of course, informed is not just Googling, right? Like often things are pressured and it's busy in appointments and doctors don't have time to explain things to us. But really their job is to help us to provide informed consent. Sending us home to Google is not adequate. They might provide you with an information sheet. If you can't understand it, they need to find someone on the team to explain it to you. But you have a right to make decisions with all the relevant information. You might need time and want to go home and do some research, but they can't delegate everything to the internet. And when I say consent, I also mean decline, right? Like the right to consent is not just the right to say yes, it's the right to say no, and it's the right to change your mind, it's the right to discontinue treatment for healthcare. So just to recap about who makes decisions really briefly, because I think I've just given you a lot of information. So who makes your healthcare decisions? The first is you. If you understand what's going on, whether or not you have dementia, you make the decisions. You have the right to appoint a substitute, and you can do that in BC through a process called getting a representation agreement. You can call First Link if you need help from someone to connect you with an organization that can help you create a representation agreement. Very rarely a family member will go to court to get guardianship for someone living with dementia if they're not able to make their own decisions and they didn't have the time to do a rep agreement themselves. And then fourth, if you don't do all this, your healthcare provider is going to be choosing someone in your family unit. So you can see why healthcare advanced planning is important. It gives you more control over who makes decisions because you could choose a friend. You don't have to choose a family member to be your representative. So what I want to do in this slide before I switch to talking about, so showing you the video, is highlight some healthcare decision-making rights that I think don't get a lot of kind of publicity or awareness raising in BC. And I'm going to talk about 3 and then talk about long-term care specifically. So first, in our healthcare consent laws, healthcare providers have a duty to communicate with you in a manner appropriate to your skills and abilities. That's right in our healthcare consent law. It's section 8, if you want to look it up. I would also say that our human rights law also reaffirms these rights. So people with disabilities have a right to accommodation of their disability-related needs in the context of receiving healthcare. So both healthcare consent law and human rights law affirm this right to communication in a way that's suitable to you. I just want to mention a few things that could be implied from that right to communication and support. It could mean for people living with dementia, not rushing the person, giving them more time to make a decision. It could mean, for example, minimizing noises or other distractions. For a lot of us, it means avoiding jargon, and healthcare providers should use plain language to talk about what your needs and options are. But every person living with dementia is different. So healthcare providers are obligated to get to know us so that they can communicate in an appropriate way. Now, the second thing I want to mention is healthcare laws also say we have a right to support with communication. So what that means is that when you're in the hospital or other kind of healthcare setting, healthcare providers should be making use of the people you trust to help you understand or demonstrate understanding of healthcare. And the support from people we trust can help people with dementia to maintain their decision-making autonomy for as long as possible. The legislation is permissive, so they don't have to let people get involved if they can see that they're not helpful, maybe they're abusive. So we do rely on healthcare providers to make some good judgments about when people are truly helpful or they're kind of meddling or controlling, and they're trying to interfere with the autonomy of a person living with dementia. It can be a hard distinction to draw sometimes. Now, third, if you've chosen someone to make decisions for you, or if you are in that position where you're making decisions for someone else, you have some duties. So substitute decision makers don't have the ability to do just whatever they want, right? They're trying to make the decision that the person living with dementia would want and stand in their shoes. And as part of that process, they have an obligation to consult with the person they represent to the greatest extent possible, and comply with your previously expressed wishes, except for wishes about admission to long-term care. You cannot bind anyone to those wishes. So what this means is that if someone is making decisions for a person living with dementia, they need to be able to talk to them and consult with them about what they want. And that's really important. And it's really important, especially during a pandemic when long-term care, there is limited access. So if you are a person who makes healthcare decisions for someone living with dementia, you need to find a way to maintain contact with physicians, nurses, or whoever is in that long-term care setting to make sure that when you make healthcare decisions, well, first they're remembering to ask you what wants to be done and getting your consent, but then that they're checking with you and allowing you to check in with that person living with dementia so that you are fulfilling your obligation to consult. So just to say a few more things about long-term care, because I know that this is a very challenging environment right now, and it's hard to fulfill these obligations about consulting. So first, in terms of consent in long-term care, a person who did not have capacity to consent to admission to long-term care because they didn't understand everything involved, they might still be capable of consenting to all or some of their treatment. So you can imagine that someone who has some progressed dementia couldn't make the decision about admission to long-term care. They couldn't understand the risks associated with living at home, and they didn't understand their care needs. But they might be able to understand if they want to be on a depression medication or a diuretic, or they might be able to make some of their healthcare decisions, but not all of them. You always need to let them try. Some treatment is agreed to in advance in that care plan. So if you were involved in the admission process, you probably had a meeting with the team at the facility and you came up with a care plan. Some treatment can be agreed to in advance. Like you might agree that certain pain medications are okay, if the person living with dementia is suffering in some way. But you can't agree to everything in advance. And in particular, antipsychotics are one thing where it's tricky to agree to in advance. And that is why the team needs to be consulting with the healthcare substitute decision maker on an ongoing way. Some treatment, like chemical restraints, has extra rules for consent. So if a person living with dementia is receiving some kinds of psychiatric medication to control them, not to treat their own depression, maybe to help them be less of a risk to themselves or others, that is called a chemical restraint. And that is a kind of medication that requires agreement in writing. And I just want to note, I'm seeing a lot of questions in the chat box, and we're going to come back to those when Lori moderates the question period. But I can see some really good questions out of the corner of my eye. So in terms of thinking about decision-making rights along the dementia journey, most of us, when we start out with a diagnosis, we can make a lot of our healthcare decisions on our own. We might go to the second box. We might need communication assistance on some days from people we trust, but then we might go back and have a day where we can do it all on our own. We might get to a point where we just need support with decision making because we can't do it on our own. And very far into the process, when our dementia is very progressed, we might have a family member as a substitute decision maker, a representative or a guardian, but you might take a long time to get there, or you might have a really bad day where you need that, and then have another day where you can make your own decisions. So although I'm presenting it as a continuum in a way that's not completely accurate because we can move back and forth along this line, but the point I want to underscore is a diagnosis of dementia doesn't mean all your legal rights to make your own decisions go away overnight. You could need support with communication, you could need support with decision making, or you might sometimes or eventually need substitute decision making, but it can take some time to get there. So I want to show you a video. And so this is a third in a 3-part series that we developed. So it's about 3 minutes long.
Protecting your decision-making rights. Sometimes healthcare professionals or family members do not respect the rights of people living with dementia. Other times you may disagree with the decision of a substitute decision maker or family member. Every time a treatment decision is needed, a healthcare professional must consider if you can understand the relevant information. If a healthcare professional assumes you cannot make decisions just because you have dementia, that is discrimination. Discrimination is against the law. Even if someone else made the decision for you to move into long-term care, you may still have the right to make some or all of your healthcare decisions. If you have a substitute decision maker because you cannot understand healthcare information, you still have the right to be involved in decision making. Your substitute should speak with you about what you want. Your substitute decision maker must follow any wishes you expressed when you were able to make your own decisions. Here are some examples of situations where you may want to talk to a lawyer. Your substitute decision maker agrees to treatment you disagree with. A healthcare professional decides you cannot make your own decisions and you disagree. A doctor is forcing you to get psychiatric care. The family member making your healthcare decisions is abusive. For legal help, you can contact Seniors First B.C. Community Legal Assistance Society, or Access Pro Bono. This video is the third of a three-part series. The other two videos are Who Makes Your Healthcare Decisions and Getting Support with Healthcare Decisions. This video covers the law in British Columbia. The law may be different in other places.
Thanks, Jess, for playing the video. So just on the, we'll just quickly show you the last two slides here. The next slide just mentions the other videos. And then the following slide, there's a picture of a booklet that we've developed with the Alzheimer Society. It's available in 4 languages, and they're all available for free on their website. And I think that they are in a link that Lori has pasted into the chat box. I just quickly scanned the chat for questions, so I'll get to them when we get to the Q&A. But now I want to pass the mic on to Myrna.
Hi, everybody. I'm really honored to be here to speak to everybody today, and I want to reach out to the person from Belleville, Ontario. That's where one of my daughters live, and so you just must be as wonderful as she is. I want to talk about the basic ideas of decision-making. First of all, I believe we all have a right and a responsibility to be happy, to live a good life, and to make our own decisions. But we can't make our decisions unless we're informed. And we can become informed. We can do research, we can listen to other people's opinions, we can ask questions of people, and we can be communicative about what we want to discuss. So again, I believe we have a right and a responsibility. Knowledge is something that we gain by learning. But the thing is, many people who develop a dementia lose a lot of self-confidence because we have disabilities. And I believe that happens to a lot of people with any type of disability. And I don't like putting people in boxes. We should all be concerned about each other. So I just want to briefly mention the basic ideas of rights of the disabled people. This is an amazing booklet from the United Nations, and it's in easy language, so it's easy for me to understand. And I just want to put out these couple of things that they have said. Number one, people are free to make their own choices. No one will be discriminated against, and disabled people have the same rights to be included in society as anyone else. So let me tell you my story. A number of years ago, I was flying from Belleville, interestingly enough, to Vancouver, to my home. And on the flight, I had a stroke. Of course, nobody knew that at the time. The plane managed, they were going to set down in Calgary, but they made it all the way home to Vancouver. And upon arriving, an ambulance met me there and accompanied myself and my granddaughter to a local hospital. I got into the hospital, and my husband and 2 other daughters met me there. And my husband and 1 daughter stayed overnight with me. And the next day I said to them, look, you guys go home. You've been here all night. You must be exhausted. And so I encouraged them to leave, which they did. But an hour after my kids and my husband left my bedside in the hospital, I was given a sleeping pill. I know it was a sleeping pill because I have taken them before, but I could not understand the reason for giving me a sleeping pill at 2:00 in the afternoon. And although I was really concerned about it, I think I was just too kind of ill at that specific time to say, hey, no, I don't want this. At any rate, they took me upstairs to the dementia ward, and that was fine, but I've never been overnight in a hospital, particularly one where there was special tools for people with dementia. Let me explain. So I got off the chair at my bedside, got into my bed, and went to sit up, and an alarm went off. So I laid back down, the alarm went off. Then a nurse came, and as she said, I'm nurse so-and-so, she was, and I'm going to do this procedure, as she was sticking something up my nose, and I said, hey, what are you doing? And she said, I'm going to do the same to your rectum. Well, I got really angry. Like, excuse me, ask me, this is my body. I have rights to, although at that moment I didn't say that. I was just absolutely mortified. Anyway, they got me all settled into bed. Then I reached over to grab a bag that was on the bedside table, and an alarm went off again. I was quite shocked by all this. I laid back down and the alarm went off. So I finally figured out that it was me moving in the bed which caused the alarm to go off. It would have been amazingly helpful for them just to tell me that I wasn't allowed to get out of bed because of my stroke, that if I tried, an alarm would go off. What a simple way to cope with that system. However, maybe 20 minutes or half an hour later, I had to get up to go to the bathroom. And of course, you know what happened. Bells went off again. Finally, the nurse that found me in the bathroom explained to me why the bells were going off, that I shouldn't get up on my own because of the stroke, etc. By this time, I was just beside myself with so many emotions, I couldn't even explain them all. And I decided that I would be much better off either in a hospital in Maple Ridge, where I live, or at home with my husband and family. So I told the nurse that I would like to go home. And she said, oh, of course not. You can't go home. It's against the rules. And I said, well, it may be, but I am going home. And she said, well, you can't. So I said, could you bring me a telephone, please? And she said, oh, no, you can't use the telephone now. And by this point, I'm beginning to feel that somebody has taken over my life without asking me. I felt like I was kind of like a prisoner. And so I cajoled a young nurse. Well, I didn't cajole her. I asked her, I said, could you please bring me a phone? And she did. And I believe she lost her job over that. She brought me a telephone. I phoned my husband and I said, please come and pick me up. However, Richmond on a Friday afternoon to Richmond from Maple Ridge is a very long way, and in Friday night traffic, it was horrendous. And after 2 hours, I was thinking, oh my God, they're in on it too. They're not going to take me out of here. So I was feeling very anxious. They arrived. I was up then, standing in the hallway, terribly upset, crying, when my husband walked in, and I said, please get me out of here. I want to leave here. And so my husband called the nurse, and the head nurse, and said, I'm taking my wife home. And she said, no, you can't. And my husband said, well, I hate to tell you this, but I am, and she is, and we have every right to do that. And to make a long story very short, they didn't want me to go, of course, and they tried everything. But my husband said to them, if you have to go get permission from somebody, how long will it take you? And the nurse said about half an hour. And my husband said, I'll give you 15 minutes. And in 15 minutes, they were back and said, oh, yes, of course she can go. Well, they probably talked to their legal representative or something. But that was the kind of situation that is so easy to fall into. And sometimes because we're so full of anxiety and because we're not feeling really, really comfortable about where we are and what we're thinking, it can be devastating. So I loved what Krista said at near the end of her description, where she said, discrimination is against the law. And I've always thought of discrimination as against it, like kind of racism, but it isn't. Nobody can discriminate against you in any way. Stand up for yourself, investigate, and be proud. Thank you for listening to me.
Thank you, Myrna. That's such a great story. You know, I think that not everyone would have sort of the courage to assert themselves in the face of that much of sort of controlling behavior. And I have so much admiration to Myrna, to you, for standing up for yourself in that context. It's so important. And it's important that, you know, Myrna's family understood what she wanted and what kind of care situation helped her to thrive and was willing to advocate on her behalf. Talking to your family about what works for you is so important. So, and I think that Myrna's story, you know, I did highlight some of the themes that I've been talking about today, and some of them are actually summarized on this, on the following slide, Jess, that has a picture of Lynn Jackson. So, you know, all adults are presumed capable of making their own decisions. This is what the law says, not the experience that Myrna had, but just because she has dementia doesn't mean she can't make her own decisions. And clearly, she demonstrates today great capacity to understand information. The other thing that's troubling to me about that experience is that Myrna was put in a specific ward for people living with dementia where she was restrained, it sounds like. And I think that has a lot to do with people being reduced to a diagnosis. But, you know, Myrna is many things, and living with dementia is one of them. But she needs care that's suited to her abilities, and an environment that creates anxiety for her is not going to help with any of her underlying health conditions. And so she made the good judgment to advocate for going home. That question about, can I leave? And I think that is a very interesting one. And unless somebody's been involuntarily committed under mental health legislation, a person has a right to leave if they have the ability to make that decision, to understand what's going on, or if their family member who's their substitute, their representative, can make that decision. Healthcare providers don't have the right to hold us in healthcare settings against our wishes. It's not jail. Sometimes that means you have to sign a piece of paper acknowledging. Thanks for your patience, everyone. There was a question in the chat box about some of the resource organizations that you can go to for or contact for help if you're in Myrna's situation or another situation where your rights are being taken away. Those organizations are listed in the booklet that appeared on the slide, and this is what the booklet looks like. Those help numbers are there. I think the thing that maybe was cut off when I leaned on the mute button is that unless you've been involuntarily committed or detained under a mental health law or the adult guardianship law, both of which are things that would rarely occur, you have a right to remove yourself from a healthcare setting like Myrna did, or your representative could. But healthcare settings are not jail, right? We can discharge ourselves. Sometimes that just means you have to sign a piece of paper acknowledging risk, so that to deal with the liability risk that they're concerned about. But you can discharge yourself against recommended advice by a medical practitioner, because remember, they don't make decisions for us, they make recommendations for us, and they're always wanting to reduce risk because, you know, they want us to be okay. So I think I'll skip this slide and pass the mic over to Jess, so you can talk about what we've been learning from consulting with people in community.
Great, thank you, Krista. So as Krista said, we've been talking to people in the community, so both people living with dementia and disabilities and care partners, about their experiences with decision-making, experiences like Myrna shared. And we've heard from people a lot of different experiences as well as strategies on how to support someone with decision-making and how to navigate decision-making as someone living with dementia. We wanted to share a few of these with you. But first, I just want to mention that we recognize that each person has unique experiences. So what we share today might not resonate with your experience, and it might not capture some experiences depending on what's happening with you, where someone's at in their dementia journey. So just keep that in mind. And as far as what decisions we've heard that people want to be involved in, we've heard that the majority of people want to be involved in all decisions as much as possible for as long as possible. And these include decisions such as healthcare decisions, like Myrna was saying, like she clearly wasn't involved in those decisions, such as treatment decisions, medication, surgery, whether or not to have certain procedures. People want to be a part of future and financial decisions, such as setting up a representation agreement or being involved in advanced care planning. And everyday decisions, such as who to spend time with, what food to eat, rest and leisure, or their schedule, and living arrangements and personal care. And then another thing that gets overlooked is that people also want to choose their level of risk and safety when they're still capable to make that decision. And that's a decision that often doesn't happen for people. We recognize that it can be very challenging for people living with dementia to be involved in decisions. We've heard a lot of barriers and challenges from people, including doubt and fear about making a decision, cognitive challenges, and sometimes not having a support person. So like Myrna was saying, not having her family there. When her husband was there, then her husband could support her decision to leave. And some of the strategies that people living with dementia have shared that they use to still engage in decision making includes communication. So asking clarifying questions when you don't understand something, asking other people for help and reminders, consulting with people you trust to get their input on a decision and to weigh pros and cons. Also, recording things can be helpful. So if you're in a conversation, like let's say at the doctor's office, you can write things down to remember later or use a recorder. A lot of people mention that. So recording the conversation with a doctor or healthcare care provider so you can go back and review afterwards. Another strategy people use is making decisions in advance as much as possible. So that would include having conversations with family about what you want or don't want, so that in case they are in that substitute decision-making role later on, they know what your wishes are. Having enough time to make a decision is important so that you can weigh pros and cons and do research. And then also making use of visual information when possible, having positive self-talk to counter some of those assumptions or negative stereotypes that you might come across. And then self-advocacy, like Myrna so clearly demonstrated, realizing you have the right to decision making and to voice that. And then also people would choose which decisions to delegate and which ones to be involved in and prioritize those decisions. We're all different people, and so some people might find that it matters to them to still be involved in certain decisions, while others, they might be okay with having a trusted person be more involved in. So besides what we've heard from people living with dementia about strategies, we've also heard strategies for how to support people living with dementia in decision making. And I'm going to share a few strategies with you, but we don't have time for all of them today. So if you are interested in reading more about this, you can go to the link at the bottom of that slide, and it will take you to a blog post that explains it more. Some important strategies for supporting people in decision making include communication, such as using simple language and visuals, using examples and stories, avoiding being too vague. And then simple things like using yes or no questions and providing limited options instead of abstract questions that might be difficult to understand. Ensuring two-way communication about decisions is really important. For really, this is again about personhood, respecting someone's wishes and not just going in with what you might want, but taking time to listen to someone's feelings and thoughts about a decision. Communicating on an emotional level is important, to listen with your heart. If someone might be beyond verbal communication, they might still be communicating their wishes through other means. And then another point is empowerment. So again, this is about respecting someone and their boundaries and personhood, to see them and not just the disease, and to respect their right to consent to treatment and to have access to information for decision making. And then learning is important to support someone, learning about things like we're talking about today. So you are all learning by being on this webinar to understand people's rights to make decisions, and then also to educate others on their decision-making rights. Offering practical support, such as driving people to appointments and being that person to weigh pros and cons with or to advocate for in a medical appointment, is a big way to support decision-making. And then an approach that you can take that's helpful is to be kind and offer emotional support to help a person feel calm and safe, the opposite of what Myrna experienced in that hospital setting, to be patient and encouraging, and then to allow enough time to make decisions, choose the time of day wisely, limit distractions for important decision-making conversations, and to build trust. Trust and relationships is the most important thing for people when they're trying to navigate decision-making, both trust with healthcare providers and family members. And this is a little snip from one of our videos, which is about how to support people in decision making. You can see that each one of these people is supporting the person in the middle in different ways so that she can still be front and center in her decision making for as long as possible. And then this is a graphic. We had a December 1st event, and at this event, this is what people told us about how other people can support their decision making. You can see a lot of those themes that we've talked about already, including the importance of the right to choose, the importance of trust, and the importance of supporting the person's capacity and increasing their confidence to decide. This is also on our blog post if you want to take the time to look at it more. We want to thank our funder, Vancouver Foundation, for making this work possible, and also thank our many other partners who have been a part of spreading the word about this work and connecting with us on it. You can get involved by participating in one of our upcoming focus groups. We're doing a virtual focus group in the spring for people living with dementia, asking them more about their decision-making experiences. And we also have key Informa interviews for healthcare providers, where we are really asking them about their practice with decision-making and looking at ways that we can support and come alongside and enhance that work. So if you are a healthcare provider, or if you know of a healthcare provider in BC, you are very welcome to contact me and we can talk about that. Later on in our project, we will be looking at resources and strategies to support decision-making and starting to implement those. So if you are interested in that and you are a community member or a healthcare provider or really anyone and you're curious about it, please do contact me and there are ways to get involved. I wanted to highlight upcoming Alzheimer Society webinars as some of them relate to decision making. I've seen in the chat a lot of questions about supported decision making and substitute decision making. If you're curious about that, you can check out the webinar on February 2nd for planning for healthcare, legal and financial decisions. And then I believe tomorrow there's a workshop with Isabel McKenzie and Jen Lyle that talks about families being essential to care. As we mentioned along this webinar, there's lots of resources. There's the link to the healthcare consent videos and other resources that are here, as well as in that handout. There's our webpage where you can find more information, including my contact information, some advanced care planning tools, and then a stigma toolkit. If you want to understand more, like Myrna was telling you about discrimination and stigma with dementia, you can check that out. Myrna, is there anything you wanted to say about that toolkit? Myrna was a part of developing it.
Just want to say that this is a really accessible tool for people with dementia, for caregivers, and for medical people. So have a look at it. It's really easy to get into.
Thanks, Myrna. Now we are ready for questions and answers. Lori, if you want to take us away.
Okay, then how do you become a substitute decision maker?
So there's a lot of resources on that, and it depends. There's different types of substitute decision making. Like Krista mentioned, there's the default when, let's say you're in a hospital and there's no legal paperwork and some decision needs to be made, then it follows that temporary substitute decision making hierarchy that goes from spouse to child. So you don't need to do anything in that case unless you want a different hierarchy. So if you want the child to make the decision instead of the spouse, then you would need to make that known. But then there are also legal ways that you can become a substitute decision making. And this includes, there's a lot of different things. So for financial decisions, there's power of attorney. You can set that up. And then there's also representation agreements. Power of attorney is only for financial decisions. A lot of people don't realize that. And then representation agreements are for healthcare, personal, and other decisions. You can visit some of the links in the resources if you want to explore those different types of substitute decision making more.
That's perfect. So is a person with a dementia diagnosis able to make a decision to proceed with MAID, medical assistance in dying? And another way that it was asked was, what about consultations about MAID and people living with dementia?
Sure. So I'm reluctant to say too much about MAID because it's a big topic and because I know we have some people from different provinces in here. And so some of the way that's rolled out, there will be some variation. But the criteria for MAID is still based in the legislation. So you have to have the irremediable suffering criteria. So, and you have to have capacity to make that decision. So there's a list of criteria that you would have to meet for MAID, and the criteria are the same for people living with dementia. People who are living with dementia have been able to access MAID over the years. It depends on having a physician that you can persuade that you meet the criteria. And there's a window of time so that if you have capacity to make the decision and set up MAID, then if your capacity, gets understanding depreciates between, you can still set it up. But you can't do advanced planning for MAID in Canada right now.
Great. Thank you very much, Krista. There was a comment made or a statement made about admission to long-term care being accepted from the list.
Yeah, I want to...
Or not binding.
Yeah, so I want to speak to that. That's a really good question. So with the substitute decision makers, like representatives, they're generally required to follow through with your previously expressed wishes, unless there's a really good, reasonable reason why they would not do that. But there's a set of legislation that applies specifically to consent to care facility admission. Where there's a law in BC called the Healthcare Consent and Care Facility Admission Act, and the Care Facility Admission Act is a different section. And that section says that there's no binding to previously expressed wishes if you're a substitute decision maker for care facility admission. And the reasons for that is that you could still put in writing that in your advanced care planning, you can say, I'd prefer not to be in long-term care. Here are the kinds of healthcare settings that I would like. I would like this. I want access to a garden. I want to be able to see my friends. You can set out what you want, and that becomes information that your healthcare decision maker must consider. But in terms of admission to long-term care, it's impossible to make an informed advanced decision about whether or not to be admitted to long-term care because you won't know what your health situation is. Whether you can make informed consent about care facility admission, you need to understand what your situation is like. What is the nature of your illness at that time? All the details. You can't make an informed advanced consent about care facility admission because it's impossible to know all the circumstances in advance. But you can certainly tell your substitute decision maker that you have a very strong preference to not live in long-term care, and this is why, and this is what you would prefer them to consider. And you can set aside money to enhance home support so that you can live at home as long as possible. You just can't bind your family members legally to an agreement not to admit you to long-term care ever.
Thank you very much. So as always, thank you everyone for your time. Huge thank you to Jess and Krista and Myrna. Really appreciate your time today.